This is Dr. Joel Janis speaking, and I'd like to share with you today an interesting case that I was involved in several years ago at the University of Pacific School of Dentistry in San Francisco. This technique is an overview of a technique where it's a non-invasive approach to a full mouth reconstruction with posterior indirect ceramic inlays and anterior composites and opening the bite. The big goal here was to not remove any tooth structure during the procedures. I taught at University of Pacific for several years, and I had a husband and a wife who were dental students. And then fast forward 20 years later, their daughter is now a dental student. Their daughter developed a problem with bulimia, and as a result, lost 2 millimeters of enamel on the occlusal surfaces of her mandibular posterior teeth and the incisal edges of her maxillary anterior teeth, and it resulted in a loss of vertical dimension. Her parents asked me if we could open the bite and satisfy her aesthetic desires without doing conventional crowns. Now, both her parents were excellent dentists. They are very, very capable of doing full mouth reconstruction with crowns, but they just were hoping that they could avoid that and not have to remove all that tooth structure. So what this photograph shows on the top, she's wearing a splint, which we made for her, but you can see how she's lost about 2 millimeters of the incisal enamel off her anterior maxillary teeth, and she was not happy with the aesthetics. If you look at the lower photograph, you can see where all of the enamel was lost off those mandibular posterior teeth. Interestingly enough, the sealants that were done are still there. So the first step was to establish correct vertical dimension, and we did that with a removable acrylic splint. We were able to open the bite 2 millimeters because her freeway space was 4 millimeters. And of course, the average freeway space is about 2 millimeters. So that gave us some room to work with. We wanted to provide space for occlusal restorations and the lengthening of the anterior teeth. So just a quick review on freeway space. The freeway space, of course, is represented by the difference in the two lower lines on the tongue blade. Or another way to say it is the difference between teeth together and the space created when the facial muscles are completely relaxed and the teeth are not touching. So by doing this, we can determine what the freeway space is. If it's greater than 2 millimeters, then we know that we can safely open the bite, but we do have limitations. So the first step, after she has worn the splint now for 2 months and not developed any TMD symptoms, it provides an opening, is to provide an opening on the premolars for composite to contact the opposing teeth. So here's how we did it. Just take an acrylic finishing burr and put holes in the buccal cusp tips. Lubricate the splint on the inside with petrolatum. Etch the buccal cusp tips of the premolars. Wash dry. Place bonding agent and light cure. Then we place composite on that buccal cusp tip and put the splint back into position Have the patient close and center it to establish the bite and light cure through the splint. We repeated that on the contralateral side to establish a new vertical dimension just on the premolars. Now the patient could still wear the splint because what we did is compatible with the occlusal pattern of the splint. But now we've corrected the centric occlusion, we've established it. At this point, we can take a face bow transfer. Take impressions and invite registration. After pouring the impressions in dental stone, we can mount the case on an articulator. So 2 millimeters of space is created for the indirect ceramic onlays to be fabricated on the molars. And again, I need to mention that we did not do any preparation on the teeth whatsoever. So now in this photograph, you can see the space created, and these indirect ceramic onlays can be fabricated on the wobble. So this picture shows the fabricated onlays, and then the onlays bonded in the patient's mouth. Looking at it from the side, we can see how we've now established the posterior segment of that new bite opening. Now we can turn our attention to the anterior teeth. And it was decided to use direct composites so that we didn't have to, if we used porcelain veneers, we would have to remove tooth structure. But with direct composite veneers, all that we're doing is adding to the tooth and not removing anything from it. And we decided to do this directly in the mouth and use the mouth as an articulator to establish our anterior guidance and canine function. So this last picture just illustrates how when the patient slides into right lateral, that they lift off on the anterior teeth, and particularly the canines, and disclude in the posterior. Question: would you have practiced this procedure on study models before you did it in the mouth or mounted on an articulator? Yes, in fact, that'd be a great idea because then you could do it with composite right on the study model and see how it works out. And that would be a guide to you when you do it directly in the mouth. So now we're going to turn our attention back to the premolars. They just have a little composite cusp tip there. We want something a little more permanent. So we take a diamond rotary instrument and remove the composite that we placed. Take impressions and invite registration, pour casts, and mount on the articulator. So now we have the space created to do the ceramic onlays on the premolars, the indirect. So we fabricate the onlays and we bond the onlays intraorally. So now all of our posterior bite is in ceramic onlays. The original treatment plan was using the idea of replacing the direct anterior composites with porcelain veneers if the patient wasn't happy with the result with the direct composite. Turns out that she was very happy with the composites and with the aesthetics and the function. And so we deferred the porcelain in order to avoid removal of tooth structure to accommodate porcelain veneers. So in conclusion, this is the before picture. This is the after picture. So we have anterior direct composite veneers, posterior indirect ceramic onlays, and we've corrected the centric occlusion with a new vertical dimension with a 2 millimeter freeway space. Now this is a different case, but I just put this in here to ask that same question. Would this be a case mounted that we would do mounted on an adjustable articulator with the face bow transfer and maybe do a mock-up ahead of time? Yes, that would be a great idea. So when we're doing these kind of cases, aesthetic cases and wide opening cases, we really want to use an adjustable articulator, face bow transfer, and we want to do a mock-up ahead of time so that we know where we're going before we begin the treatment. And that's it.